Welcome to the deep dive. So, you gave us this stack of research trying to get to the bottom of the U.S. healthcare cost crisis. And what really jumps out, immediately, is that the system isn't just complex. It feels like it's been intentionally locked down.
That's a great way to put it. It's locked down, and when you strip away all the jargon and the politics, the material really points to two core regulatory problems.
Yeah.
They're like these two handcuffs on the entire market.
And our job today is to kind of unpack those mechanisms, see how they keep prices so high, and understand why the obvious fixes, like let's just hire more staff or let's use new technology, just don't seem to be working.
Exactly. And the two constraints are surprisingly simple to name, but their combined effect is just devastating.
Okay, so let's just dive right in. What are they?
The first one is the 1997 Residency Cap.
Right.
That's the federal law that puts a hard limit on how many new physicians we're allowed to train every year. It's basically a system of artificial scarcity.
Which means fewer doctors, less competition for jobs, and, well, higher salaries. A classic supply problem.
A classic supply problem. And the second one is all about incentives. It's the 85% medical loss ratio, or MLR.
Okay, and this rule says insurance companies have to spend 85 cents of every dollar they get in premiums on actual medical care.
On care or on things directly related to care, yes. But here's the paradox that just breaks the whole market.
It's that their profit, the 15% they're allowed to keep, is based on that total spending pie.
That's the kicker. If the total hospital bill is, say, $10,000, the insurer gets to keep $1,500. But if they do their job and negotiate that bill down to $5,000,
their profit gets cut in half to $750.
Right. They are literally, legally incentivized to keep prices high, or at the very least, to not fight very hard to lower them.
So our mission today is pretty clear. We need to see how the system actually functions with these two things in place, restricted supply and completely backward incentives, and figure out why all the fixes we try just seem to make the bubble bigger. So let's start with a question from the research that I just think is brilliant. The sources call it the nurse practitioner paradox. The number of nurse practitioners, NPs, and physician assistants, PAs, has absolutely exploded in the last decade. So why haven't the costs for a basic checkup gone down at all?
Yeah, it's a great question. Because if this were, a normal functioning market, all that cheaper labor would create instant competition.
You'd see independent NP clinics popping up everywhere, right?
Yes.
Undercutting the big hospitals.
Absolutely. You'd see low-cost clinics driving the price down for everyone. But that is not what happened.
So what happened instead?
The big hospital systems, who were already struggling with the doctor shortage from the 1997 cap, they just absorbed all this new labor. They hired almost all of them.
And that creates this huge opportunity for what the sources call shadow pricing. It's an arbitrage play.
It is pure arbitrage.
Yeah.
The hospital pays the NP a good salary, sure, but it's a lot less than what a doctor makes. Then they use their muscle, their negotiating power with the insurer, to bill for that NP's service at, get this, 85 to 100% of the full physician rate.
Wow. So all the savings from using cheaper labor get captured as pure profit by the hospital.
Every penny. The patient doesn't get a lower copay. The insurer doesn't pay a lower claim. It's just a wealth transfer, straight to the hospital's bottom line.
And this is where the two core problems we talked about just lock together perfectly.
They do. Because the MLR, that 85% rule, makes the insurance company a happy partner in this whole scheme. They see a big $300 claim for a visit that might have cost the hospital $150 in labor, and they are fine with it. Because a bigger total claim means their 15% slice is also bigger. The system is built to protect inefficiency.
Okay, but let me play devil's advocate for a second. The hospitals always argue they need that extra margin to cover things like charity care or the ER, right?
That's the standard defense, yes. But the research really suggests that this kind of cross-subsidization is incredibly inefficient. It's opaque. When you inflate the price of everything to cover those other costs, you have zero pressure to actually figure out where your money is going. The better fix, the one economists favor, is to just separate those things. Fund charity care with a transparent mechanism, not by secretly overcharging for every other procedure in the building. So if using cheaper labor doesn't actually lead to cheaper prices, the conversation has to go back to the most expensive labor of all, the doctor.
And this gets us into what the sources call the brain drain trap. It's the big fear, right? If we uncap residencies, flood the market with doctors, and those huge six-figure salaries come down, won't all the smartest people just go into finance or tech instead?
It's a critical question. And that fear is 100% correct, as long as we keep the current U.S. education model.
Because students are taking on $300,000 in debt.
On average, yes.
Yeah.
And spending, what, 15 years in training? Under that system, a huge salary is the only thing that makes that choice rational.
So it's a vicious cycle. The doctor shortage keeps wages high, which justifies the insane tuition, which then means the wages have to stay high to pay it all off.
Precisely. Which is why the solution, the circuit breaker, as the sources call it, can't be about protecting wages. It has to be about crushing the cost of education itself.
But how do you do that? How do you force medical schools to slash tuition when they're basically a cartel?
You introduce competition, real competition. You uncap the residency spots and open the doors to fully trained international doctors. And this is where it gets really interesting. Suddenly you have a wave of doctors who went to school in, say, Germany or the UK, where tuition is tiny or even free. They have zero debt.
So they could afford to work for a normal professional salary. They don't need $500,000 a year to make the math work.
It's exactly right. And when your market is full of debt-free, very competent doctors, the U.S. medical schools have an existential crisis on their hands. They can't keep charging $300,000 because the student's return on investment just disappears. They would have to adapt, either slash tuition or maybe adopt those faster 6-year undergraduate medical degrees you see in Europe.
So you change what it means to be a doctor economically. It stops being a career you take on to pay off debt, and it goes back to being a vocation that is also financially stable.
And, to really get how deep this artificial scarcity runs,
Yeah.
you have to look at the history here. It's pretty stunning.
We talked about the AMA, the American Medical Association, lobbying for the 1997 cap. That's a classic guild move, right? Protecting your members by limiting supply.
It's a textbook example of regulatory capture.
Right.
And it's not just the cap. The AMA also controls the LCME.
The committee that accredits medical schools.
Right. So they effectively have a veto over any new school opening or any existing school trying to expand. They control the whole pipeline.
So it's not just a cap at the end. They're controlling the spigot at the very beginning.
They are. And what's really wild is that this isn't new. The research points to what it calls a secret prequel, the Flexner Report of 1910.
Okay, I've heard of this.
Yeah. This report was supposedly all about improving quality. But what it actually did was consolidate the whole system. It shut down tons of schools, taking the number from around 160 down to just 66.
And in the name of quality, it created this blueprint for scarcity that we've been using for over a century.
That's it. Use quality control as your public reason for creating an artificial shortage, which makes the remaining doctors way more money. And that history directly informs how big corporate players are thinking about this today, like in the big McKinsey Gathering Storm report.
Right, and that report says correctly that the old model of the general hospital is inefficient and failing. Their solution is moving to focused factories, these specialized ambulatory surgery centers.
Which is a good idea. Specialization is efficient. But here's the technocratic trap, as the sources call it. McKinsey sees the labor shortage. They know it's a problem. But instead of saying, hey, let's lift the cap and train more doctors, they propose a technological solution. Exactly. Their plan is to lean on AI and automation to fill the gap, spend billions on proprietary software to make the few doctors we have maybe 10% faster.
So it's a technological patch on a structural problem.
It's a defense mechanism against real change. And what's worse, even if it worked, you wouldn't see the savings. Because without repealing the MLR, the insurers will just count the cost of that expensive AI toward their 85% spending, and the whole system stays just as bloated. Technology can't fix a broken incentive.
Okay, before we get to the actual two-step solution, we have to tackle the big counter-argument you always hear, that the problem isn't the system, it's us. We're sicker, we're older, we use too much tech, we practice defensive medicine. It's a consumption problem.
It's an argument that feels true, It's intuitive. But the data just doesn't back it up. There was a landmark McKinsey study back in 2008 that looked at exactly this, accounting for the cost of U.S. healthcare.
And what did it find when it compared our usage to other countries?
Something that just blows your mind. Americans do not consume more healthcare. In fact, we have fewer doctor visits and fewer hospital days per person than the average European.
So we aren't running to the doctor more than people in France or Germany.
Not at all. We are just paying an astronomical premium for every single thing we do consume. The problem is price. Period.
So let's break that down for the listener. Let's put these cost drivers into clear buckets.
Good idea. Let's say bucket A is the scarcity tax. These are all the costs that exist because the market is broken. Competition would solve these.
Okay, what's in there?
You've got consolidation, Independent doctors can't survive, so they sell it to monopolies. You've got massive administrative bloat, which the MLR actually encourages because it counts as part of that 85% spend. And of course, a total lack of price transparency, which is what monopolies love.
So that's why a specialist's office needs a whole team just to handle paperwork that shouldn't even exist.
It's exactly why. Now, bucket B is the reality drivers. These are real costs that competition won't just magically fix.
Like our aging population.
Right. And chronic disease. Demand is going to keep rising. But we have to fix the price per unit of care first. And, defensive medicine, the fear of lawsuits, it's real. But the estimates put it at only a 2 to 3% of total spending. It's a rounding error compared to the monopoly pricing.
And one quick question on geography. This focused factory model sounds great for cities where most people live. What about rural America?
For rural areas, the model becomes more of a regional hub. It means, yeah, for a big non-emergency surgery, you might have to drive 2 hours. But if that 2-hour drive saves you $10,000 compared to the local monopoly hospital, it becomes a very clear choice. So look, if you take just one thing away from this deep dive, it should be this. Fixing the U.S. healthcare crisis does not require some massive 10-year political war. It's not a total revolution.
It's about cutting the two ropes that have been tying the market's hands.
That's it. Rope number 1. Lift the 1997 residency cap. Let the supply of doctors actually meet the demand. Let competition force the cost of medical school down to a sane level.
And rope number 2. Repeal the medical loss ratio. Make it so insurance companies profit by being efficient and lowering costs, not by enabling higher prices.
You do those two things, you remove those two hurdles, and the market can finally start doing its job. But here's the final thought I want to leave you with, kind of a provocative idea. If the cost of becoming a doctor was radically lower, if it wasn't tied to this mountain of debt, how quickly would the whole idea of being a doctor change? It would stop being this golden cage defined by salary and go back to being a vocation, defined by pure talent and the desire to heal. What other amazing changes will flow from that one shift?